The impact of the Affordable Care Act on healthcare access, cost, and quality by Joy Borkowsky, Kimberly Carter, Stephanie Dargan, Kaya Lewis, and Sara Warner. The Federal Patient Protection and Affordable Care Act, signed March 23, 2010, as amended by the Healthcare and Education Reconciliation Act, signed March 31, 2010, is also referred to as the Affordable Care Act, or simply as Federal Health Reform. The intention of the ACA is to expand access to insurance, increase customer protections and wellness, improve quality and system performance, expand health workforce, and curb rising healthcare costs. Under the ACA, more people have access to health insurance. Most U.S. citizens and legal residents, low-income and impoverished persons and families, employees of large companies, persons with pre-existing conditions, and young adults are now covered. Through the Affordable Care Act, most U.S. citizens and legal residents are covered, meaning they now have access to purchase coverage through state-based American health benefits exchanges. Through these exchanges, individuals can review their health insurance option and choose the plan that best fits their needs. However, most U.S. citizens and legal residents are required to have health coverage. If they do not, they will pay a tax penalty. Medicaid benefits were expanded to cover people with incomes up to 133% of federal poverty guidelines, meaning that a family size of 3 could be covered by Medicaid up to $24,644.90 instead of $18,530 as before the ACA. This raise of the Medicaid guidelines could have significant impact on low-income families, meaning that more people can be covered under Medicaid services and not have to worry about the additional cost of health insurance. Additionally, Medicaid was also expanded to cover all non-Medicare eligible individuals under the age of 65 to include children, pregnant women, parents, and adults without dependent children with incomes up to 133% federal poverty guidelines. Also included in the ACA are employer requirements. Employers with more than 200 employees are now required to enroll employees into health insurance plans offered by the employer. Small employers can purchase coverage through exchanges and may be eligible for tax credits. Under the Affordable Care Act, those with pre-existing conditions are now covered, meaning that as of January 1, 2014, health insurance companies cannot refuse to cover, charge more, or limit benefits to a person with a pre-existing condition. A pre-existing condition is a health problem that a person had before the new health coverage starts. Some examples of pre-existing conditions are asthma, diabetes, and cancer. Young adults up to the age of 26 are now covered on their parents' health insurance policy if the plan covers children. Children can join or remain on a parent's plan even if they are married, not living with their parents, attending school, not financially dependent on their parents, eligible to enroll in their employer's plan. When a child turns 26, the coverage ends. However, the child now qualifies for a special enrollment period, which lets them enroll in a health insurance plan outside the open enrollment. Exchanges, also called marketplaces, are services available in every state that allow small businesses, families, and individuals to review and enroll in affordable medical coverage. The purpose of exchange programs is to offer health insurance coverage to those not covered through employers or other social services such as Medicare, Medicaid, or CHIP. As part of the Affordable Care Act, signed into law by Barack Obama on March 23, 2010, all states must offer a state exchange program or participate in the federal exchange program. States that have established their own health exchange programs must operate off a common framework designated by the ACA, but have some flexibility to create systems that reflect the practical and political needs of their states. Both state and federal exchanges must offer essential health benefits, such as prescription drug coverage, emergency room care, hospitalization, doctor visits, maternity, mental health services, rehabilitation, laboratory services, and preventative care services. Each state has the option of participating in the federal-run exchange program, creating their own state-run exchange program, or combining some state services with federal assistance. There are 4 types of health insurance exchanges. Federally facilitated are those exchanges where the Department of Health and Human Services performs all health exchange functions and enrollment is done through healthcare.gov. State-based health exchanges are completely run by individual states. The states are responsible for performing all health exchange functions for individuals and small businesses. The enrollment is through state-established websites. State-based with federal platform are exchanges where the individual state operates the health exchange but uses the federal facilitated IT platform. Enrollment is through healthcare.gov. State-federal partnerships are exchanges in which states control plan management and administer customer assistance, but HHS performs remaining health exchange functions. Enrollment is also through healthcare.gov. As of 2017, 12 states have created and are using state-run exchanges. 5 states are using state exchanges with federal platforms. There are 6 state-federal partnerships. The majority, 28 states, are using the federal exchange program. The ACA is made up of 2 separate pieces of legislation, the Patient Protection and Affordable Care Act and the Healthcare and Education Reconciliation Act of 2010. These 2 acts and the combination of their contents have enabled the expansion of Medicaid insurance coverage. Medicaid is the largest and most important component of the nation's healthcare safety net. Medicaid offers insurance for the poorest and most medically vulnerable Americans. The 2 basic functions of Medicaid are to provide insurance to low-income adults and children and to fund the expansion and expand long-term services and support to patients with serious illnesses or disabilities who are at risk of impoverishment as a result of their health. The ACA offered 5 years of additional funding for CHIP. This program provides coverage to children and families who earn too much to qualify for Medicaid. The ACA also provides full federal funding for newly eligible populations from 2014 through 2016. Federal funding will phase down to 90% by 2020 and thereafter. At one time, it was optional for state contributions. Now the ACA requires the states to contribute to the employee premium share in order to give poor workers with access to employer coverage the means to afford it. In addition, the ACA amended Medicaid's outpatient prescription drug program to give states higher rebates for covered drugs and to extend the rebate program to Medicaid managed care plans. Out-of-pocket costs may include co-payments, co-insurance, deductibles, and other similar charges. States can impose higher charges for target groups that exceed the federal poverty level. State expansion decisions may be impacting marketplace premiums. One study found that marketplace premiums are about 7% lower in expansion compared to non-expansion states. Some of the key implementation challenges facing state and national policymakers are deliberate state opposition, legislative differences, executive orders, and Supreme Court lawsuits. The ACA relies extensively on cooperation of states for implementation. This creates a number of roadblocks. State responses have varied widely, ranging from enthusiastic support to uncompromising opposition. Some states, such as Florida, who outright refused to implement any component of the ACA, has even went so far as returning the funding given to the states for implementation. These states also immediately joined the lawsuit against the ACA and have no plans on implementing any state exchanges. Most of these states have a Republican governor and a Republican attorney general as well. Florida and Louisiana, who were fully controlled by a Republican party, are an example of 2 states who outright refused to implement any of the ACA laws. They were frontline and center in the ACA lawsuit. There were many states where opposition party affiliations made it difficult to establish exchanges. Legislative differences led to mixed opinions and delay on exchange systems. Some states jumped at the opportunity to implement the ACA. They did so by effectively establishing exchanges under the ACA and refraining from joining lawsuits. This was done by a variety of Democratic-leaning states and one or two Republican states, such as California, where a Republican governor came out and supported the ACA from the very beginning. These states were generally eager to reform their insurance markets, and although there was some Republican opposition, they were able to move forward. There were quite a few bipartisan states where state and local officials could not agree on what to do. These states either established an exchange but still joined the lawsuit, or did not establish an exchange because of funding. Many of these bipartisan states have created exchanges under executive orders, but have many stipulations due to legislative opposition. The Tea Party's blatant opposition also posed a problem for bipartisan states. Their influence prevented some exchanges from happening and influenced other states to join the lawsuit. Executive orders were signed by officials in some states where legislators could not come into agreement on the ACA. States such as New York and Rhode Island were not able to overcome a divided legislature and required an executive order to move forward. Rhode Island politicians failed to agree on legislation. Executive orders were signed by the governors to move forward with implementation, although all weren't in agreement. After searching for months to find an attorney who would take their case, House Republicans made good on their threat to sue the Obama administration. The lawsuit challenged the president's authority to enact key parts of the ACA. This lawsuit, later thrown out by the Supreme Court, had high participation from many of the opposing states. The lawsuit accused the Obama administration of unlawfully postponing the requirement that large employers offer health coverage to their full-time employees or pay penalties. The lawsuit also claimed that the giveaway of roughly $175 billion to insurance companies was unlawful. According to the Congressional Budget Office, the administration will pay that amount to companies over the next 10 years, though the funding has not been appropriated by Congress. The ACA is a controversial piece of legislation. Its design was so complicated it had to be rolled out in pieces over 5 years. One of the biggest political debates has been over the cost. However, true cost is difficult to pin down. Original estimates were that the ACA would reduce the national debt by $143 billion. This would be accomplished through new taxes. In addition to new taxes, the ACA initiated some cost-saving policies such as reducing drug subsidies to the wealthy, refusing hospital DSH payments, and reducing the reimbursement payments made by Medicare and Medicare Advantage plans. The cost ended up being approximately $940 billion over 10 years. Part of the cost was coming from the expansion of Medicaid, setting up the exchange systems and developing the various tax credits to help consumers pay for this insurance. The cost estimates keep changing, but the newest estimates are as high as $1.5 trillion over 10 years. The access to care part of the political debate led to the expansion of Medicaid in all but 19 states. This allows for more people to enroll in Medicaid. The expansion also provided tax credits for consumers up to 400% of the poverty level to help pay for the premiums for the insurance. One example is a family of four making $97,000 a year is now eligible for a tax credit to offset the fees. This is a chart of the 2017 federal poverty levels. Please note that Medicaid expansion allows people with an income of up to 138% above the federal poverty level to have access to health care via Medicaid. Another political debate is that the ACA changed the reimbursement model for both inpatient hospital care and outpatient visits. Reimbursements are based on how the entity meets the quality standards set up by the ACA. Outpatient sites are becoming patient-centered medical homes, one-stop shopping for the patient, and allows the caregiver to better track patient outcomes. A higher reimbursement can be gained by meeting the matrix for being an accountable care organization. This offers even tighter monitoring of care and treatment of patients. Monitoring for reimbursement is made possible through electronic medical records. The ACA mandated that providers move to an electronic medical record system to document patient visits or face penalties. Physicians and institutions are incentivized for early adoption of electronic medical record systems and meeting the matrix set up by the Meaningful Use Program. The ACA utilizes electronic medical records to track disease trends and conditions for various populations. Using this information, the Population Health Initiative was created. Population health is designed to implement health education to areas based on their needs. Population health is designed to help people seek preventative health services before they have a health crisis. The ACA has been a positive impact on many Americans. An individual can no longer be denied health care coverage due to a pre-existing condition. Many more people have access to health insurance, and the Medicaid and CHIP programs were expanded to cover more people. Insurance plans must provide minimal essential services under every plan. Young adults are allowed to stay on their parents' insurance until age 26. Not everyone has benefited from the ACA. There are large upfront costs, and some taxes were increased to help pay for the expanded coverage and startup. People no longer have an option to refuse coverage without paying a fine. Many Americans are finding that health insurance premiums are significantly increasing, and employers are having to pay more as well. Some employers have even cut employee hours to part-time to avoid paying insurance. Thank you.